Hi, everyone, and thank you for joining us for today's webinar, Understanding the New Landscape of Anti-Obesity Medications, Evidence to Applied Practice. I'm Marianne Murphy, VP here at Medical Fitness Association. Today's webinar is sponsored by Health One, creators of nutritionally complete meal replacement products and turnkey comprehensive and tailorable health improvement solutions, partnering with you to positively impact the health of your communities and organizations. Now, I'd like to take a brief moment to introduce today's presenter. Dr. Renee Rogers is an expert in developing biobehavioral healthy lifestyle interventions for obesity treatment with a special focus on physical activity and relevant strategies to promote long-term success. She has worked in weight management and physical activity research and programming for 20 plus years, playing many professional roles that include working as an instructor, practitioner, program director, researcher, designer, and consultant and strategist to large corporations. She blends her background in theater and production with her formal academic training in exercise physiology, behavior change, and weight management to develop and implement innovative promotion, physical activity, and weight management initiatives that encourage well-being and healthy lifestyle engagement. Her current work is focused on the body composition, behavioral, and lifestyle factors related to contemporary obesity treatments and pharmacotherapy. I knew I was going to mess up that word, pharmacotherapy. Dr. Rogers also serves in leadership and committee roles for the American College of Sports Medicine and the Obesity Society. Now, if you have any questions as we move through today's webinar, go ahead and type them in the question or chat section of your toolbar, and all questions will be answered in the end in the order they were received. Okay, Dr. Rogers, take it away.
Awesome. Thank you so much. I am so excited to be here, everyone, with you, and really appreciative to the Medical Fitness Association for inviting me to do not just one, but two webinars on this topic. And when we had the initial discussion, we really felt like it was important to break this content up because there's so much there. And one of my concerns for our industry and, the obesity treatment space in general is a lot of people are oversimplifying this concept of these new, very effective, highly effective medications into a simple solution. When the reality is, it's actually quite complex. And I feel like, as a professional, and as a profession, we really need to get a good, strong foundation and really, truly what this treatment paradigm looks like, what these medications are about. So today, as the title says, we're really going to get into more of understanding the medical management, what these drugs are, what they do, and also take a deep dive into some of the evidence on physical activity that I think is relevant and important for us to look at, but also put some cautionary flags out there. Our next webinar, we're going to dive deeper into really programming strategies, some considerations for our businesses as owners and operators and what we're doing and maybe where we should and shouldn't be going, and also some information from our research on patient perspectives. So excited to get started with you now. So let's get into this. There we go. So really quickly, as a professional disclosure, yes, I am. I have, my own consulting services that I offer, and currently consulting with a company called Wonder Health. It's not related to anything that I will be talking about today, but my personal disclosure is that I am an obesity treatment advocate. And I say this because from the standpoint of, I am an exercise physiologist. I am, behavioral training, obesity care has been my career, as Marianne mentioned in my biography, but that relates to all treatment opportunities related to obesity. So I do believe in pharmacotherapy when appropriate. I believe in bariatric surgery when appropriate. And I hate to use the word believe. I want to make sure that patients get access to the things that they need so all folks can receive the medical management and treatment for all chronic diseases. So I am not a stick my fork in the lifestyle only camp. I am a believer in lifestyle as a foundation, though, for everything that we do, which you'll see as we talk today. So as mentioned in my, but just to give you a little bit more understanding of who I am, I mentioned I am an exercise physiologist by training, and I've worn a lot of hats, as you've heard from my bio. But my higher education training, when I got to that point in my career where I realized I didn't know enough and I really wanted to help people with physical activity engagement and chronic disease and obesity management, I received my PhD specializing in not just exercise physiology, but the relationship with behavior change, and mental health, and also obesity and related diseases. So my world all collides around these important concepts. And I call myself my research primarily in the applied application work that I do in my consulting biobehavioral, because everything I do is designed around thinking about the biology of exercise and what the research tells us, the evidence tells us in changing biology. But then beyond that, how we apply it to the human that's in front of us, understand their behavior and perspectives for ultimate engagement. So getting into this, I want to say this at the top is living with obesity isn't easy. And I want to remind us all of that. And then beyond that, treating obesity isn't easy, even in this new age of effective anti-obesity medications. Obesity is a very complex disease. So I just want to remind the audience of that if you're looking at this as a business opportunity, or you're looking at this as a quick fix, or you're seeing this as patients going down this pipeline, really reframe your thinking and pause and step back and say to yourself, okay, I need to remember as a practitioner, as an owner operator, whoever I am, the human with obesity is living with this, and it's not always easy. And for practitioners, not just yourself, but the medical management team, it's not always the easiest thing to treat, even when there's highly effective medications in our hand. And with that being said, this is if any of you have followed me previously on LinkedIn, I know I had the link in my profile. I'll have it again and during the Q&A portion up on the screen. But this is one thing that I felt strongly about in all my years, and I will continue to say this, is obesity treatment always needs to be person-centered, not method-centered. And I'm not just speaking towards physical activity, I'm speaking towards treatment. So weight loss industry has always followed that pattern of, this is the method. I have the method for you. This is the pill. This is the supplement. This is the exercise program that's going to help you maximize your weight loss. When the reality is it needs to be more person-centered. Obesity is extraordinarily complex. So the objectives that we listed out in our webinar for today really hit on 3 of so many points that we can talk about. The first being to really just help you understand a little bit more about the application and the effectiveness of these medications, and also help to provide you with an understanding of how they're indicated, medically managed, some of the side effects, what comprehensive obesity care truly looks like, and also finish up today with an understanding of what we know and what we don't know about physical activity research in this space. And spoiler alert, we don't know a lot. And there's a lot of claims being made out there, and there's a lot of folks throwing programming recommendations out there. I think we want to step lightly with caution, and I'll help provide you with what we do know and where we're going and some of the research that's ongoing. And next time, we're really going to deep dive into this. But today, we'll just give you an overview. So I wanted to start with this because this is actually a post that I put out on LinkedIn about a month ago. And it was my PSA, I said, for fitness professionals regarding anti-obesity medications. And, a lot of the work that I do is collaborating, in the obesity treatment space. But it's also, I always feel like I sit in the middle, right in the middle of the exercise world and the obesity world. And part of my loyalty to our profession, I really want to continue to educate our fitness professionals across the board of how we should and shouldn't potentially be talking about these, because I think it does really play an important role when we start to talk about being on comprehensive care teams, when we look at all the work that's happening about reimbursement and getting exercise professionals reimbursed and our services that are out there. We want to make sure we're talking about things in an educated way. And this is a fast moving space, folks. So we want to watch that. One thing we're saying today isn't the wrong thing that we're saying tomorrow. And I've even corrected some of the language that I've initially used since I started presenting on this topic over the last couple of years. So I have 3 stops and 1 do. And let's start with the stops. So my stop recommendation is stop calling anti-obesity medications weight loss drugs. We're going to dive into that in a minute. Stop calling all anti-obesity medications Ozempic. 3, Stop making claims that resistance training and exercise programs will stop lean mass or muscle mass loss. Really important distinction that we'll get into again here in a moment. But here's our do. Our do. Do read more, do study more, just like all of you are here today. Congratulations on that step, of course. Evidence about what we do and do not know about the role of physical activity. There are a lot of people making a lot of claims out there right now. And it's really important for us to step back and evaluate things from an evidence-based perspective. So hopefully I can try and shed some light on that today. So I think this post, surprisingly, as I was reflecting and preparing for today, I thought this is probably going to be really good to try to dive into because it does help to tell some of the story for our first webinar. So first one, stop calling anti-obesity medications weight loss drugs. This comes from the understanding that the FDA has approved these medications for the treatment of obesity. And we'll dive into the basically the indications of this here in a couple minutes, but this is for the treatment of obesity. It is not for modest weight loss. And I know every single one of you probably on this webinar right now are saying to yourself, but people are using it that way. They're getting these medications, all these different things. I agree wholeheartedly. But that doesn't mean as an industry that we need to jump on that bandwagon, right? We need to be recognizing that they are appropriately being prescribed for the treatment of obesity, which is a chronic disease as named by the American Medical Association over 10 years ago. We've been talking about this because obesity does not just mean excess weight, right? Or excess adiposity. That is a starting point for the definition. It is much, much, much more complex. It is a complex collision between our biological metabolic dysfunction, our behaviors, of course, and also our environment, what's around us. It is way more complex than simplifying it to eat less and move more. And I bring this slide up courtesy of a colleague, Dr. Robert Kushner. And Dr. Kushner is, and I ask everyone, the slides that I'm presenting today, please be respectful and do not share. I have many colleagues that have given me permission to use their intellectual property that they've worked really hard on. So hopefully, please, for educational purposes, I'd appreciate that. But this is just really looking at all of the complications affecting every organ system essentially in the body. And you can see what's in purple is where we have the strongest evidence. What's in gray, which you see there's barely any gray up on that screen anymore, or lighter purple is where we have less or moderate, or, weak or moderate evidence. But you're seeing this amazingly, right? Almost every body system out there. And it doesn't mean that every patient has this. It doesn't mean that every patient's at risk for all of these things. Some are and some aren't. We know genetics and phenotype play a role and an impact in this. But the complexity of obesity isn't just about reducing body weight. It's really about treating the human and anything else and any other risks that can be happening from a biological perspective. So I think that, as we start to dive into this first point of today's talk and understanding application and effectiveness of these medications, we need to go back to that first point that living with and treating obesity are not always easy things to do. So again, another wonderful slide credit to Dr. Robert Kushner. And this is typically in the medical management of obesity, not just pharmacotherapy. The way that it's perceived in this pyramid, you also often see used. The Obesity Medical Association also has another schematic where it's kind of level 1, where you start, level 2, where you go, level 3, where you go in terms of medical management. And I like that, but I tend to like this pyramid a little bit more because, as Dr. Kushner puts it beautifully, you notice that physical activity, healthy eating, and behavior modification, and also I want to add to that mental health, psychological support as needed, really are the foundation. And he talks about it as being the foundation of any treatment, which is great news for us. This is what we do every day, right? And it's really important as we talk about being integrated on medical management care teams. But being the foundation or being the shoulders at which help carry the success of the other medical management strategies, which are medications and surgery, right? So typically how it's been done is we encourage patients, right, to go on a healthy lifestyle journey first. And it's not so that they fail at it first, it's so that they create a foundation. And then at that point, if we find that the lifestyle intervention on its own isn't enough for certain reasons, biologically we'll talk about, medication can be added. If we find at that layer that medications may not be enough, bariatric surgery may be the more appropriate step for certain patients. But at the end of the day, the healthy lifestyle remains the foundation. And this, I love this slide. I recently presented the American College of Sports Medicine annual meeting with Dr. Caroline Apovian, obesity specialist from Harvard, and she's incredible. And this is a slide adapted from Dr. Lou Aroney's work over the years, and it's continuing to adapt, and new medications are being added. But what you're seeing in the white is what we get, starting with lifestyle. It's kind of following that lifestyle to red in medication to blue in surgery, if you look at this diagram. And what you're seeing is that on average, when someone initiates a diet and lifestyle program, this slide's showing that the effect is under 5% weight loss. I will say in our clinical university-based, highly intensive research studies of healthy individuals looking to lose weight with obesity, we can get upwards of 8 to 10% weight loss and sustain that for over a year. However, in translation to commercial settings, commercial weight loss programs, you may see somewhere between 5 and 7% weight loss. But again, those numbers can fluctuate, and there's an incredible amount of variability across people. So in your mind, if you're saying, no, I've had people lose way more weight than that, some people, right? We have to remember the extreme variability. But as we start to get into the landscape of medications in red, you start to see that some of our earlier medications, which we could call generation 1 or generation 2 medications, we're helping to increase the percent weight loss that you see patients. So things like orlistat, phentermine, now trexone, bupropion, phentermine, topiramate. These are the earlier generations of medications. You saw that they helped bump things up a little bit more. And then it's not listed on this slide. We had a medication, liraglutide, which I'll talk about in a minute, was one of our first GLP-1s that came out. That bumped things up a little bit more. But now we're in this new generation, or this third generation, where we're seeing medications like semaglutide and tirzepatide nearing the weight losses that we see with bariatric surgery, which you can see semaglutide's right there with lap band procedures, which we don't see as many of them being performed anymore. But tirzepatide, the newest kid on the block, is actually doing better than lap band and getting closer to sleeve gastrectomy and gastric bypass surgery. So we still see, as Dr. Apovian stated in her talk, that bariatric surgery currently provides the best results. It's still the best out there, but some of our newer agents in the pipeline are looking very promising at catching up. So we've evolved, and the landscape will continue to evolve. So with that being said, you saw all the medications that are out there already approved, that are out there that could be used for treatment. So why do I say stop calling all these medications Ozempic? Ozempic is one medication in a very large pipeline. So let's dive into this a little bit more. So, what's in a name? They're not all Ozempic. And I presented this slide many, many times over again, and I think I get the most questions about this, but it is confusing. The space is moving really fast, but you need to step back and remember that these medications were originally built for the treatment of type 2 diabetes. And once we realized that they were, efficacious for treating type 2 diabetes, researchers started to notice people were losing a substantial amount of weight while taking them as well. So they were then further studied in individuals without type 2 diabetes to understand how much weight is actually lost and to see if they were appropriate to be approved for weight management, obesity treatment. So as I mentioned, we're calling these newer drugs, these newer iterations, I should say, not newer drugs, iterations of the medications, as second, if you talk to some people, but more and more people are calling them third generation medications in terms of obesity management. Some folks refer to them as incretin-based hormone agonists, and we'll talk about an agonist, what that means here in a moment. But really the name, that the appropriate terminology is nutrient-stimulated hormone therapies, or NUSH therapies. And we're broadening this category. If you notice, I am not calling them GLP-1s, because what you're going to see down the line is that while GLP-1 has been the crux of semaglutide and liraglutide, the previous generation, and it is also a portion of what is being stimulated with tirzepatide, one of our other medications, It is not the end all be all. It is a big portion of it, but many different nutrient stimulated hormones in combination with one another are being studied right now for new medications and mechanisms. And we'll get to that here in a moment. So again, GLP-1, it's a hot thing to say. Ozembic's a hot thing to say. It's a hot thing to hashtag, but really you may be selling yourself short in this landscape. And again, I'm seeing people developing fitness programs around GLP-1s, certifications around GLP-1s. I think we want to really just pause a little bit and make sure at least that we're using the right terminology, especially as we look to partner with medical groups. So semaglutide, Ozempic, is for the treatment of type 2 diabetes. Another reason why we don't want to call it for weight loss or for, obesity treatment. We don't want to call Ozempic the way that we go, even though lots of the world does. We want to step up our game. Truly, it's Wegovy, which is the FDA-approved medication approved in 2021 for obesity treatment. When it comes to tirzepatide, our new kid on the block, Mounjaro, is for the treatment of type 2 diabetes, but just FDA approved at the end of 2023, November of 2023. In fact, I presented at MFA in October and said, it's going to be any day now, this is going to get approved. And then only a few weeks later did it actually happen. So these therapies have been around. The GLP-1 mechanism has been around for, we've been studying for close to 15 to 20 years now with these earlier iterations of liraglutide. You may have heard of Saxenda or Victoza or dulaglutide, which is actually Trulicity. So you've probably heard a commercial about that. So we have been looking at GLP-1 for quite some time and studying it. So if you hear people say these drugs are so new, we have no idea what's going on with them, there are certain things that we're still studying and trying to understand. But from a safety efficacy perspective, we've been looking at these for quite some time. So what was a big shift here? And actually, this was a phase 2 study early on of semaglutide when they were trying to understand the efficacy of it. And they compared it to an earlier generation liraglutide. And what was striking about this is that for the first time, we saw this using the GLP-1 structure in terms of a medication strategy, that there was actually essentially a doubling of weight loss, which makes this a third generation or the next generation medication. So early on, they really were seeing high levels of efficacy in terms of weight loss. So we went from somewhere around 7% to 15% in comparison with the other drug. So specifically to speak to semaglutide, and tirzepatide is a very similar pattern to it. Just to give you a little general background on it, I'm not going to go through the chemical structure and what makes it slightly different and all of those things, but to help you understand in terms of the efficacy of what's really happening. Remember, initially studied for the treatment of type 2 diabetes. So we're seeing an increase in insulin biosynthesis and secretion in our pancreas. We're seeing an increase in insulin sensitivity, especially in the liver, really positive benefits in that area. And then from a GI perspective, a slowing of gastric emptying in the GI tract. And then in the neurological side, in the brain, the gut-brain axis, we like to call it, that connection, we're seeing a decrease in appetite. And we'll get into this a little bit more here in a moment, but that's really the efficacy of what's happening in order to help with the inducing weight loss. Adverse side effects are an increase in nausea, vomiting, and other GI side effects we'll hit in greater detail. There are some reports of a slightly elevated heart rate that needs to be considered, and how much of that impacts us in the exercise space. A little bit still unknown, but we need to investigate that. And there is pancreatitis risk in anyone, that has a previous family history of thyroid cancers, different things along those lines. There's some really, really good screening that should be going into this. It's critically important. So what is it about semaglutide? I showed you a phase 2 study, which is early on, but this is a phase 3 when looking at a project where there was an intensive lifestyle intervention compared to semaglutide plus intensive lifestyle intervention. So lifestyle intervention was included in both of these trials, but they call placebo, that's the lifestyle intervention in this case, because there was no drug given, but you saw that the lifestyle group reduced their body weight by about 5.76% body weight over the course of 68 weeks compared to semaglutide that achieved a 16% reduction in body weight. So again, lifestyle was incorporated into that, right? So it's really important to remember that, but that's a pretty significant number over the course of just over a year. And in addition to that, there's been several studies of semaglutide that have come out with long-term outcomes at this point now. But this one is this is a step 5 trial, subjects without type 2 diabetes specifically. We saw that even after 104 weeks, 2 years out, right, that participants lose the majority of the weight in the first year, but they're able to maintain it as long as they're staying on that dose of the medication. And like with anything else, folks, you come off a medication, you stop eating the right way, you stop being physically active. Like any treatment, when you take a treatment away, regain happens. So it just like anything else, taking a medication, getting a medication, access to medication is a behavior, just like access to a gym, access to trainers, access to all these things, right? So treatment goes away, weight loss increase, or weight loss goes away as well too, we should say. Quickly about tirzepatide, I won't dive in quite as much, but the difference with tirzepatide and the reasons why we're seeing a greater amount of weight loss are being heavily studied right now. One of the speculations is that I mentioned to you that we're targeting the receptor for GLP-1. So all of these medications work by not actually putting GLP-1 in your body, or GIP in the case of tirzepatide as well, into the body. It's actually mimicking those hormones in the body. And when they mimic those hormones, they're able to go forward in a simplistic way of saying it, turn on the receptor, stimulate the receptor for those hormones. So they're called agonists, right? They're turning on a receptor. So semaglutide works by turning on GLP-1, that receptor for GLP-1. Tirzepatide, we like to call this a dual agonist because it turns on both GLP-1 and GIP. And it may be that the combination of those two is what is increasing the amount of weight loss. Again, the role it has on appetite, fat metabolism, energy balance it's still unclear, where there's still lots of work to do to try to understand it. But we do see some of the similar changes in appetite, and I'll point that out here on a slide coming up. But when it comes to tirzepatide, and again, in subjects without type 2 diabetes, this was Dr. Jesterbaugh's phase 3 clinical trial, the primary efficacy study for tirzepatide. And this is looking at different doses. And you're seeing at the highest dose of tirzepatide, 15 milligrams, which is the darkest blue bar, you're seeing that about a 23% weight loss after about 72 weeks, pretty significant. And there are many, many, many studies going on with semaglutide currently and tirzepatide in this space. So what are they doing? Well, John Blundell has done a, extraordinarily job. He's one of the experts in the space of understanding hunger and satiety and eating, all these regulatory biological mechanisms around it in his work over the years. But one of the things, and piggybacking off of them, that these medications are doing are, they're reducing hunger, the drive to consume, they're increasing satiety, and that's that end state of satisfaction. So not getting hungry in between meals, that feeling. They increase fullness. They increase wanting, right? That wanting, or the motivation to consume specific foods, like cravings. They increase satiation, and satiation is important because that's that moment where, again, the gut-brain axis of when you put food in your stomach, it's sending signals up to the brain to tell you when it's time to stop. And we know that there's dysregulation in people with obesity, that there's a dysregulation in that signal. So now these medications seem to be helping with folks eating some and then finding that signal coming back that's saying, I'm full, it's time to stop. We also see a decrease in liking or hedonic behavior, so sensory pleasure that comes with eating certain foods, and then prospective food consumption, always thinking about food, right? So when we look at these satiety hormones and some of these hunger hormones that are being targeted, these nutrient-stimulated hormones with all the medications in the pipeline, semaglutide and tirzepatide are the two medications that are approved, but others are coming, trust me, folks. And what they're doing is they're connecting that gut-brain axis so that the reward center of the brain is dampened down. We're not having food noise or constantly thinking about food throughout our day, but our hunger center is more regulated in terms of helping us know when we're full, when we're not, so that we can be more content between meals. So indications, medical management, side effects. I think a lot of this, many of you have probably heard, so I don't want to spend too much time on it. But there's a difference between qualifying for a medication and a medication truly being indicated. And I want to point this out because we use BMI currently as the qualifier, right? And that can be highly problematic. We know in the fitness profession that this idea of BMI is flawed for many reasons. It's not taking full body composition into account. We know that someone very muscular can have a high BMI. So there's problems, right? So that's why we say qualifying is different from indications. Now, BMI qualifications are the following. You can have a BMI of 27 or greater with an obesity-related co-condition, heart disease, hypertension, hyperlipidemia, type 2 diabetes, and you would qualify for one of these medications. Or you can have a BMI of 30 or greater without a co-condition and qualify. Again, does that mean that you should be indicated? Absolutely not. And this is where there are many systems, modalities, businesses, methods coming out where patients are able to say, self-report, this is how much I weigh, this is how tall I am. And all of a sudden they qualify for a medication and they're being prescribed a medication without comprehensive medical evaluation and management. And my obesity specialty trained colleagues are over and over again, if you follow any of them or you follow me, you be connected, how they talk about the importance of good, strong evaluation, which actually includes labs, comprehensive medical history, making sure there's already a foundation of physical activity there, because evaluation is critically important for things like pancreatitis and the thyroid conditions that may be, a consideration for patients. But in addition to this, right, we need to be thinking about, are you taking a medication that's actually inducing your weight loss? And if we took you off that medication, what would that do before we put you on something else? What is it about other things going on? Are there other underlying conditions that you don't even know you have, right? So medical evaluation is critically important. So I think as you hear about different things or different opportunities you can have, I think one of your biggest questions as a fitness professional or an owner operator is, what does the medical management look like and how are patients being followed? There's lots of things that happen, right? With these meds, they change how they're dosed, prescribed, critically important. So in addition to that, administration. These medications, once you are qualified and it is indicated for you, a discussion between you and the medical provider, administration is by an injection. These injectable pens, I have a picture on the screen of what Wegovy looks like. They are, injectable pens that you titrate, you click the dose to the appropriate amount and put it in. You will get a consistent amount of the correct dose of these medications. They're on a weekly basis for semaglutide and tirzepatide. However, liraglutide is something that is taken on a daily basis. Newer medications that are out there are being studied for less than that. Some are trying to do a monthly injection or a less frequent injection. So it's quite amazing. It can be injected into the thigh, the abdomen, or the arm currently is what's recommended. In terms of dosing, yes, there are package indications where over the course of time, it titrates up naturally. However, I will tell you, proper dosing is between the medical provider and the patient. It comes down to the combination of tolerance, side effects, and how they're doing. Many people experience doing just fine at the lowest dose. Other people will be fine for a certain amount of time and need to go up. It is so individualized and so variable. So again, the importance of the discussion with the provider and the connection with the provider, I cannot underscore anymore. These are complex medications that need to be titrated up and down as appropriate and medically managed, hands-on medical management. Side effects, as I mentioned, GI side effects are the most prominent. They are mild to moderate. Everybody's different in terms of their tolerance with side effects, but at the end of the day, we need to remember that, they need to be monitored and managed. We do see that for some people, they go away 48 to 72 hours after injection or over the course of the week. They tend to get better after they've been on the medication. They can improve when a dose comes up. They typically will experience more, but it can get better. Again, it's very individualized. So I think saying people experience these horrible things, some do and some don't. There's also many patients that say, no problems here. I don't have any of these GI side effects. And again, that's our biological genetic variability probably playing a role. But again, dietary changes and increased physical activity, when we talk about comprehensive treatment care, it's all encompassing, all inclusive. It's the foundation of medical management. as I checked this morning, it appears that there are 100 plus agents currently in development. So they're not all Ozempic. Remember that. They're not all Ozempic. And this slide is actually a little bit outdated now, but this is from Dr. Carolina Povian. But I love showing this as a big perspective. I'll have to get this updated here. But we have everything from GLP-1 single receptor agonist. We have new antagonists, dual new antagonists that are going to be turning off receptors that are in development. Amgen's 133 or Maritide is an example of that, where we're seeing that these drugs there's a GLP-1 is being turned on in one and GIP is being turned off, and they're showing early on to look very promising. Many of these have moved into phase 2. And then we have retatrutide, the one box all the way to your right, which is a triple receptor agonist. So, and this is in phase 3 clinical trials now. So this is just a snapshot of some of these that look really promising, but you can see there's lots of different nutrient stimulated hormones in this relationship, turning on, turning off. So we want to call these obesity medications because they're complex, and we don't want to call them all Ozempic. So let's talk about what's different from lifestyle in the last piece of time that I have, and get in a little bit more into the physical activity data. So I love this example, and I have to give full credit to Dr. Lee Kaplan for this work. But, we can do a lot with physical activity and dietary changings with folks. And that's the foundation of all of the work that I do. But we have to recognize that for some people biologically with long-term obesity or metabolic dysfunction phenotypes, we see that it just doesn't work anymore. So what I think about is, and I love this inner tube example, and the first picture to your left is called above set point weight. And when we talk about set point weight, we're talking about the body's defended fat mass of where it wants to stay and where it wants to belong. And that's, from a homeostatic perspective, from a functional perspective, it's to preserve energy, right? We're humans, our bodies are miraculously designed to do this, right? But when we talk about a weight set point, that's the point of where your body's always going to want to try to hang. So when we first get someone to lose weight, even through diet and exercise, right? It's like dropping an inner tube on the water. If you hold that inner tube above the water and you drop it, right? It plops right down and it stops on that surface of the water. And that's an example of gravity helping, right? You're getting down to a place where your body's like, sure, you can lose some of that weight, no problem. I'm not going to give you a hard time about it. But once you hit the surface of the water, right, the inner tube, all of a sudden now you have gravity pushing down, but you got buoyancy pushing back up. And I want you to swap out the word buoyancy for biology. And think that that's typically what's happening to our bodies when we start to try to create a reduced caloric state. Our body starts to say, hey, whoa, you can go to that set point, but when you try to go below it, I'm going to push you right back up. That could be our plateaus. We talk about breaking plateaus all the time, right? But it's not as simple as just changing up your workout program or changing what you eat or reducing your calories more. Sometimes it truly is a biological underpinning that's forcing it back up. And when we really try to push, have you ever tried to push an inner tube underwater, how hard it is, right? The buoyancy doubles down. And that's what our body's doing too. It's doubling on us in terms of biology and trying to force our weight back up. So what biology are we talking about? Well, when you schematically map this out, as Dr. Kaplan has done here, you see that in restrictive eating states, right, when we're trying to go below that fat mass, that purple dotted line, when we try to go below that level, what we see, whether it's restrictive eating or with high energy expenditure through physical activity, either way, we're reducing calories, right, energy expenditure. We see that biological physical compensation in the form of increased appetite and drive, and also energy conservation, as I mentioned. So we see people feeling hungrier. So that's why it's hard to sustain those diets. It's hard to stay on that high energy expenditure physical activity plan, right? It becomes hard to do all of this work when you're struggling with being hungry all the time because the body's trying to get you back up. And that's a sign from a biological dysregulation that probably someone is ready for some pharmacotherapy. So that being said, now let's get into the exercise portions of this and talk. I know that was a lot about it, but I think we really need to remain educated on what these drugs are doing and what this means for us. We know a lot about physical activity, right? But really how these tie together becomes our next layer for today. We're just going to touch the surface of the physical activity. We'll get into it more next time. So My colleague and I, John Jakisik, who's also with me at the University of Kansas Medical Center, we were asked by the American College of Sports Medicine early on to write a blog about, and if you're, anyway, followed ACSM, you may have seen this, but to really talk about this idea of where's our perspective? Where do we think this is going early on before it really got on most people's radar? So there is a QR code there if you have a moment to scan it. But challenges are the first thing, but we also talk about opportunities. But our challenges are the first thing that we want to point out. And we all know this, right? And we could react negatively to it. But with the light of day, we need to be honest. People are losing a significant amount of weight without engaging in activity. They're going to improve many health parameters without engaging in activity. And they may not see the value of activity in terms of losing weight. And for a lot of years, right, we framed exercise as being important for weight loss, or it's been inappropriately in some ways framed for weight loss, which should have been probably for health. So people have a perception of what exercise does in this relationship that maybe we need to change. So I'll get into opportunities, but before I do that, I want to say, however, this is where my third claim comes in. We want to stop making claims that resistance training and exercise programs will stop lean mass loss and muscle mass loss, because we still have a lot of research to do to actually know this. And I'll talk to you more about some of the details. So the work that I'm currently doing at KUMC, a lot of our research is focused on the biology and the behavior. But, we've done this work for a long time. We know that eating behavior and changing physical activity will change your body weight, your body composition, and that will lead to health outcomes. That's the paradigm we all follow every day. These medications are being studied from everything from, the medications changing type 2 diabetes, improving obesity status, cardiovascular disease, the SELECT trial. Now we have an approval on the label for Wegovy for semaglutide for cardiovascular indications, right? Because we've seen amazing results in terms of hard cardiovascular outcomes. Recent data on obstructive sleep apnea has come out. The FLOW trial was just stopped early because there was so much success in kidney function. We're now seeing liver functional improvements with semaglutide and more coming down the pipeline. So this is real, this paradigm. So now what we're trying to do is understand the same paradigm we've looked at before, but what happens when you give someone a medication? And what other factors come into play? So how is the medication impacting eating behavior? How is it impacting body composition specifically? That's my strong area, my strong area of focus right now. But in addition to that, what other factors are coming into play? And what is the role of exercise and physical activity? Like, we really don't know at this point. We can speculate from what we know, but there's a lot of other things. So again, with Dr. Apovian and Dr. Jakisik led this article. This is an open access article from the Translational Journal of the American College of Sports Medicine. Thank you to MFA. I know you've posted this quite a few times for members, so you may have seen this already. But I want to highlight a figure from this diagram. And as I've mentioned, obesity treatment is shared, right? But for many years, we've thought about it as lifestyle versus pharmacotherapy versus metabolic bariatric surgery. The reality is, as we've already discussed, that's not really what it is. And any patient that's engaging with pharmacotherapy or metabolic bariatric surgery should absolutely be doing the same with lifestyle. But in addition to that, patients that start with lifestyle may need that biological assist from pharmacotherapy, or they may down the line realize that, they need that surgery for help. It's every patient's individualized. And when we speak of lifestyle, we think about this combination of physical activity, behavioral counseling, and nutrition and dietary counseling. So there's many other diagrams and things in here, but this comprehensive approach is really critically important. And I encourage you all to grab this if you're ever looking for justifications for treatment. We really tried to design this paper to help bring perspective forward on that. Another paper that we've published with, it's in obesity currently, and my colleague, Dr. Tim Church and John Jakisik and I, again, put this one together. And this really gets into, I know, the crux of what so many of us are interested in and understanding. Wow, I know this is complex. I'll show you a little simplified diagram here in a minute. But when we look at this, right, we have thinking about the role the medications play versus the role that exercise plays. And I'll break this down here in a moment. But let's really talk about what we know about body composition, to my claim that I want you to stop saying. And that is, this goes way back to our very low calorie diets. And I think these slides are really important to point out to all of you, because These best mimic what we're actually seeing in terms of caloric consumption with patients on these medications because of the appetite suppression. Bottom line is in these studies, what we had is 4 groups: a diet-only group, a diet plus endurance, or a diet plus resistance, or a diet plus combined group. Weight loss paradigm. And when we looked at this across the board, what we saw is that in 90 days, everybody lost weight. No surprise, right? You're reducing calories, you're being active, wonderful. Everybody lost fat mass. Everybody lost lean mass. And let me show you this because this is important because everyone in the world out there is saying it is critically important for everyone to do resistance training. You must do resistance training. You must do resistance training. You must, because you're going to stop lean mass loss. Well, folks, even in a hypocaloric state that mimics what patients are seeing, we do not see resistance training stopping lean mass loss. Is that the full story? Absolutely not. When we did muscle biopsies in these studies by Dr. Donnelly's group, we saw that was when it came to strength, right? We saw biological improvements, but when we did a strength index as well, when you did any form of resistance training or combined training, strength did improve. When you did cardiorespiratory training, surprise everyone, right? The principle of specificity, endurance training improved, right? Fitness improved in those paradigms, right? So as we look at all of this, we have to remember that telling someone that we're going to stop your lean mass loss or your muscle mass loss is likely not the case. But can we improve the quality of the tissue and the functionality? Absolutely. And that's what's really important to our patients. My current line of research right now is, we know these medications are doing a lot of great things. And we do speculate that there is a 25 to 40% reduction in lean mass. Those numbers are variable. We want to be careful with those. We know that's a problem. We think it's a problem, right? But we do see that patients overall are functioning better to a certain degree. However, we have no idea how much of the lean mass is actually muscle mass. In fact, it's not been measured in any of the studies to our knowledge at this point. And that's the current work that we're actually doing right now. So don't use lean mass and muscle mass interchangeably as well. We don't actually know those numbers. Yes, should we be concerned about lean mass? Sure. We need to pay attention to it. We need to understand it. But should we be making claims that we can stop lean mass loss? I'd be very careful about that. I'm going to skip past these ones just for time's sake today, but some of the early trials of liraglutide, if you notice this reference, it's up here, they have incorporated exercise training. The one thing when we think about the outcomes of that study, we want to be careful about is that liraglutide is not as effective as semaglutide. So remember I showed you early on, semaglutide is giving us double the weight loss. So I'm not sure that exercise in that relationship will be the same with semaglutide or tirzepatide. So more research to be done, which again is our current study that we're running. But I bring you back to our obesity paper because I think this puts it in perspective for you as you think about exercise and how you talk to patients about exercise we know these medications are reducing adiposity. We know that they're reducing adiposity-related conditions and improving health and well-being. We believe that there is a significant increase in lean mass. However, we have no idea how much of that is actually muscle. Let's be careful there. Physical activity in all its glory. We know it can help to reduce adiposity. We know that it can help potentially sustain or help with the reductions in lean muscle mass, maybe, depending on the hypocaloric state. When you're in a hypocaloric state is very different when you're in a full-fed state in exercise training. We have to remember that. We know that it can help with sarcopenic-related conditions, resistance training across the board, muscle health and function. And we know if we cannot attenuate muscle loss or lean mass loss, we can improve muscle quality and function no matter what. So how we speak of it, I think, is critically important. And again, we know exercise does all these things outside of weight loss and body composition that we can't neglect. So my recommendation to all of you, let's move away from saying exercise to preserve muscle or slow or stop muscle loss. And let's move to saying we're here to support your muscle health, your quality of life, and your physical function. We do have evidence for that. So I mentioned the challenges, the opportunities. There's so many of them. And very quickly, we're going to deep dive into this next time in our webinar. We now have the opportunity to start talking about the dose of physical activity different. It doesn't have to be about high energy expenditure. We can really talk about specific health related needs of the human that's standing in front of us. And we can also think broader about how we can be better members of a comprehensive support team, not just develop stuff for the fitness industry to thrive, but develop comprehensive programming, be on comprehensive care teams, become reimbursed members in the obesity treatment paradigm. It's really about the bigger picture. So in our next webinar, we're going to deep dive into exercise prescription. I will talk to you a little bit more about my current biological and behavioral research paradigms, more recommendations, what we can say at this point or what we should be considering, and also taking a step back as we think about the opportunities for our businesses and our practices and our fitness centers. And where we're at with all of that. So I go back to the beginning. Hopefully I explained these points in a little bit deeper detail and gave you a little more evidence, even more evidence to come next time. And I hope you're seeing how complex this can really be, and that by us slapping a method on or telling somebody they must resistance train or all of these things really makes us method-centered rather than being person-centered when this can be quite complex. So I'm going to stop there so we have some time for questions and say thank you. And this is the link to my LinkedIn profile if we're not connected. I hope we all connect and we can keep the conversation going.
Awesome. Well, thank you so much. That was wonderful. We do have a couple of questions up already. First question is, I've known people taking anti-obesity medication and they are not eating enough food a day to even function daily. They feel weak, low desire to do any activities, even to cook or play with their kids. How do we as medical professionals talk about this and help those that are not eating enough on these medications?
Such a really important question. And thank you for asking that, because, I've spoken a lot to providers, and I think, you talk about some very relevant, important quality of life issues that people are experiencing. And I think sometimes in our fitness bubble, we think about, well, if they're not eating enough, they're not going to be able to perform. But for the human with obesity, right? And that is true, right? That's absolutely true. Or if they're not taking in enough protein, how will they build muscle? All of those things, right, are a big part of this. But you're really putting this, thank you for bringing it to a human light, like not playing with your kids, not cooking. Those are quality of life issues that I think are critically important. And you're bringing up a great point. When we talk about the appetite regulation, that hedonic desire, I had those bubbles up on the screen. Those are really real things that substantially help some people, but they squash other things in other people. And that's why the mass prescription of this, without really considering the mental health aspects that go with it, without having conversations like you're mentioning, are critically important. And I can tell you, it's a hard conversation to have from my experience, because many patients say, for the first time in my life, I'm not thinking about food and I am losing weight. And that desire to lose weight and to feel better sometimes trumps their desire to want to cook or be with their kids. And that can be a really complex thing. So I think as medical providers, as medical professionals, if you're seeing these kinds of patterns in someone, of course, it's always good to say, hey, is it okay to have a conversation about some of these things? I'm noticing a change. Ask for permission first to discuss these things. And if you know it's outside of your scope of practice, have your referrals ready. Who is that clinical psychologist that understands obesity treatment that you can readily refer to? Talk to folks about saying, like, this is complex. I'm here to help you with your exercise, your physical activity behavior change. Dietitians help you with the diet. How can we get you to one of those folks? How can I help get you to a behavioral psychologist that can help you bring all of this together? Because as I mentioned, we're not the only pillar of that foundation. It's the comprehensive lifestyle team together. And so you're bringing up a wonderful point. We need to pay attention to this.
Awesome. So, and just to remind everybody, if you do have questions for Dr. Rogers, you can go ahead and put it in the Q&A section or even in the chat section, either or. So Michael has a question. He says, from a biopsychosocial perspective, what can be done upstream to intervene early in the course of excess adiposity? Unfortunately, this doesn't seem to be part of the conversation, and it is after the fact when COVID conditions become evident.
Yeah, it's a hard question, right? So excess adiposity is something that, as we mentioned, there's absolutely behavioral considerations in there, right? I mean, the choices we make in terms of foods, different things, right? Our food environment, the environment plays a big role. what we have access to. We cannot ignore those things. These are large systems issues that really require some level of change. But we also have to remember that the genotyping and the phenotyping of the human and their, genetic susceptibility to carrying excess body weight, excess adiposity. Those are things we cannot control. Those other things contribute to that, right? So that's why I always like to show that the overlapping of those different things. I think we want to be really careful, especially in our space, that we don't cross that line of saying, well, now that these drugs are here, we're not talking about prevention anymore. There are a lot of people, I think, that are still trying to systematically look at prevention. And as I said, systems change. There's a great group on obesity solutions. The National Academies has a roundtable on obesity where they're really trying to look at all of the aspects of the systems that come together in terms of prevention across the board. I think all of the things around education on physical activity and healthy eating early are something that, we can educate through the wazoo. We still need to keep doing it, but there are, gaps in that work. But I do want to say we want to be cautious in realizing that these aren't separate entities, they're combined entities, and some things we can control and some things we can't. I encourage everyone to take a look at Ted Kyle and his conscience group. He writes a lot about this concept of prevention isn't dead, but prevention will likely not also be the thing that changes someone's genetic susceptibility. It may contribute to it or not. So some really good things that help us put all of these things in perspective and balance one another. It's a hard topic, I know.
Yeah, it's a big topic.
Big topic.
Sandra has a question. Is there any research on weight loss outcomes for individuals who stop the medication but continue with exercise, healthy eating, and other positive behavior changes?
Yeah. So great question. And with these medications, semaglutide and tirzepatide, the answer is no. The liraglutide study that I did skip, maybe, I'll say it's maybe. And what they saw is when you took exercise alone versus liraglutide as the drug versus liraglutide plus exercise, it appears that addition of exercise to liraglutide, even when the treatment stops, may have a more favorable, everybody regained weight, unfortunately, just being honest, right? But if you had exercised, that regain trajectory wasn't quite as steep and quite as fast. So some are speculating when you look at the body composition data that it could be because of the body composition changes. I will tell you the exercise intervention was a little boggy in how they describe it. It was kind of a combined thing. I don't know if it was the best. I suspect many of you on this call would probably prescribe something maybe more tailored and a little bit more concise as we're trying to do in our projects. So the answer is we don't know. And I say this again, the role of exercise and weight maintenance has always been important for, creating that additional energy gap. We're very interested in not just understanding the relationship of, when you're exercising, when you're on it, what it looks like, but what happens when you come off of it, as you mentioned. But also some colleagues are saying, what does this mean in terms of dose? If someone is very physically active, does that mean that they don't have as much of a dose of the medication, or they can lower a dose of medication? We don't know, but these studies are starting to happen now. And I think it's a very exciting time, because I know sometimes you talk about lifestyle to deprescribe, and that's great. That's wonderful. But in chronic things like this, chronic situations, we have to remember that sometimes deprescribing isn't possible completely, but maybe it could be a de-escalation. We don't know. Or intermittent treatment. We don't know. There's so many exciting questions, but thank you for that. That's a wonderful, wonderful question. You're on the cusp of thinking.
Yeah, it seems like we still have quite a ways to go.
Oh, so much.
Oh, wow. Corley just says, thank you. This was excellent. Can't wait to hear part 2. Again, folks, if you have questions, you can go ahead and type them in the Q&A portion or in the chat section. Either or is fine. So while we're waiting for more questions to come in, I'll just say thank you so much, Dr. Rogers, for sharing your knowledge with us today. All attendees will receive an email with a speaker evaluation for today's webinar, and it includes a spot to indicate which CEC you would like to receive. Even if you don't need a CEC, I hope you will complete the evaluation, because your feedback helps us in planning educational webinars, and it helps our speakers with their presentation skills. I don't think that's needed here, but I'll just throw it out there.
Yeah. And please,
Getting-
anybody please connect with me on LinkedIn. And I really hope you come back next week because we have so much more to talk about.
Yes, it is big. We're getting lots of thank yous. I don't have a question, but thank you so much. Great information. So yes, just a reminder, and I will include this in the follow-up email, that this was part 1 of a series of 2 webinars. And so Dr. Rogers will be back next Wednesday, June 26th, again at noon Eastern time. Part 2 is adapting programming in the new landscape of anti-obesity medications, biological, behavioral, and business considerations. So that'll be our deeper dive. And like I said, I will include a link in the email with the speaker evaluation. Just a quick thing for those of you who are in the Midwest, we are holding a medical fitness symposium on August 8th. This one-day event will be held at the Michigan Athletic Club in East Lansing. We've got a lot of great speakers, so check out on the website at medicalfitness.org for more information. And again, thank you to our webinar sponsor, Health One. You can visit them online at hnthealth.com for more information about creating engaging programs together. And I'm not seeing any more questions here other than lots of thank yous. So thank you for joining us today. And thank you to Dr. Rogers for sharing her time and knowledge with us. Enjoy the rest of your day, everyone.
Thank you, everyone.